If a patient has hirsutism and amenorrhea and they are reproductive age, remember the most common cause of this hirsutism is PCOS. Also look for more significant signs of hyperandrogenism, such as scars from nodulocystic acne. There is a non-classic version of congenital adrenal hyperplasia, or otherwise known as late onset congenital adrenal hyperplasia, which is usually caused by a partial 21 hydroxylase deficiency. Whenever you see partial 21 hydroxylase deficiency, just think of increased androgens. The reason why this is non-classic is because this is a partial defect, so you really don't see symptoms until the patient is in adolescence or early adulthood. Very, very rarely when you have a partial defect will you see clitoromegaly or voice deepening. These are more extreme levels of viralization. Usually you will just see a patient with abnormal uterine bleeding. Always be careful to see if the patient has oral contraceptives. This can mask amenorrhea. I would go about my diagnosis by checking for elevated 17-hydroxyprogesterone. You also do an ACTH stimulation test. I like to think about this with a mnemonic of someone who is almost 21 years old. This represents being partially 21, aka partial 21 hydroxylase deficiency. When I think of someone who is almost 21 years old, I think of them as a growing adult and they will have increased androgen levels. I'm thinking of a male in this specific case. With anger, you might act like a 17-year-old. So I will have elevated 17-hydroxyprogesterone, and to test whether or not I have this deficiency, I will give an ACTH test. That is how I memorize non-classic congenital adrenal hyper. The treatment for this is hydrocortisone. If you see a newborn with internal genitalia that's male, but female external genitalia, think of 5-alpha reductase deficiency. You can also see patients with 5-alpha reductase deficiency with no uterus, and therefore it can present as if you have a female appearing patient that has not gone through menses. Remember, if you suspect anorexia nervosa, BMI has to be less than 18.5, and also look for dark hair on the back. This is called lanugo. Now, if a patient has abnormal uterine bleeding, never forget to think about granulosa cell tumors. These are estrogen-producing tumors. Now, if I have a patient, and this is key, have rapid onset hirsutism, think Sertoli-Leydig cell tumors. But again, there's so much androgen production that you actually have viralization. So like I mentioned earlier, you will have things like clitoromegaly. Get an ultrasound for these patients and look for an adnexal mass.